Good morning, good afternoon, and good evening, everyone from different parts of the world. Welcome to this parallel session of the World Hepatitis Summit, reaching communities that need it most. I hope you are enjoying this summit. Lots of session, lots of presentation from experts from different fields, representative from national and international organizations, policymakers, and others. Well, for me, at least, it has been a great learning experience, and I hope you all share the same view. I'm Dr. Anindra Rahman, along with Andrew, who is Technical Advisor in TB HIV Care. We are co-chair for this session. And a little bit about me, I'm from Bangladesh. I'm the Program Manager for National Viral Hepatitis Control Program there. So as Tedros said yesterday, there are some diseases that can be eliminated, and hepatitis is one of them. However, if we want to achieve our target of 2030, we need to be smart about our strategy. One of the important strategic decisions will be to reach out the risk group first, vulnerable groups who have or are in risk of higher prevalence of hepatitis or higher impact of hepatitis. So in this session, we will have some exciting talk on this area. I will hand over the mic to Andrew to introduce the speaker and begin the next session. Andrew.
Great, thank you. So from me in South Africa, welcome. It's really fantastic to see this wonderful panel of people who are going to be presenting from a range of contexts from Southeast Asia and also from Europe, particularly the United Kingdom. And I think just knowing that we should never leave people behind and the importance of community-led responses and working with people for solutions is really critical. And in today's session, we're going to hear from Dr. Hassan from Malaysia, Dr. Cristiana Merendero from Portugal, Dr. Kanudeep Kaur from India, Mr. Bonet from the United Kingdom, and Tanya Porn Wasam from Thailand. And we look forward to getting a very diverse perspective of why it's so important that communities are engaged. So without further ado, I'd like to welcome and introduce Dr. Muhammad Radzi Abu Hassan, who is the head of internal medicine from the Ministry of Health in Malaysia. He is a consultant physician and gastroenterologist and also head of the clinical research hospital at the Sultana Bahia Altor Sada Kedah Hospital in Malaysia. And he's going to be talking about going beyond the low-hanging fruit, key population-specific strategies to tackle hepatitis C in Malaysia.
The title of my presentation is Going Beyond Low-Hanging Fruits, Designing Key Population-Specific Strategies to Tackle Hepatitis C in Malaysia. As we're all aware that the number of patients being treated of hepatitis C seems to be plateau, and as you can see on this graph here that from 2017, after the introductions of the soft debt following our compulsory licensing, the number seems to slow down after 2020. The whole reasons why this phenomenon occurred in Malaysia simply because the initial treatments was mainly focusing on the patients who are people who inject drug, which is they are all linked to our healthcare system via opioid replacement therapy. But having said that, there are many of the patients who are still unreached, or for some reason they are not coming to our healthcare system. Still out there untreated. So these are the people like the unreached people who inject drug, these are the people who have been using alternative substance abuser, fishermen, estate worker, island residents, and there are also other group of people, for example, like people living in a correctional setting, MSMs, sex workers, and people living with HIV and their partners. So we have to go beyond this. So the purpose of the study of this project is to design statewide key population-specific strategy to scale up hepatitis C virus screening and treatment through a government-community partnership. It was conducted in the state of Kedah, one of the states in Malaysia with the highest number of people who inject drug in the country, and also the second lowest median household income in the country. The study design was a qualitative study. It is in collaboration with the Ministry of Health and the other two CSO, which is the Malaysian AIDS Council and also the DNDi. The study populations consist of members of public health system, and local CSO who actively engage in or supported the hepatitis C virus treatment in Kedah State. The data was collected from 5 sessions of focus group discussions, which consists of about 10 to 12 participants each. Facilitators were myself and also was assisted by another doctor. There were 2 note takers, and the framework of the study is to pre-identify the key populations, and the analysis method was on thematic analysis. Who constituted the focus group discussions? There are the public health specialists, the family medicine physicians, environment health officer, and 2 groups from the CSO delegates. So 2 teams emerge from focus group discussions. There are government-led strategy and also the CSO-led strategies. Of course, the strategy overlap a lot between the 2 groups. So what are the government-led strategy? The first one is to extend hepatitis C virus screening services to private GP with oral replacement therapy. Secondly, to promote screening in partners of HIV-infected patients in our primary healthcare center. Offer on-site screening services and treatment in places with a high people who inject drug, and also kratom user density. Kratom user density is a new substance, so-called a new substance abuse trend in Kedah. Provide more promotional material in primary healthcare centers. So for the CSO-led strategy, we propose encourage the uptake of hepatitis C self-testing among MSM via social media and dating apps, to promote hepatitis C virus screening among sex workers and their clients, to set screening booths in places where drug trades and sex activities are common, and to link people under surveillance and also the ex-prisoner to healthcare. So what we have achieved so far, validating the need to reach out to underserved hepatitis C virus key population, deepening the partnership between the public health system and the CSOs, setting a tone for strategy planning in other states in Malaysia to scale up hepatitis C virus screening and treatment. So in conclusion, ladies and gentlemen, the findings highlight the importance of community engagement to complement local public health authorities in driving the outreach to undiagnosed hepatitis C virus patients and treatment scale up in Malaysia. With that, I thank you for your attention.
Thank you very much, Mr. Hassan, for this wonderful presentation. I think we learned a lot about how you are engaging the communities in your planning, and this is really commendable stuff. And I think all of us who are here will take note how to implement this kind of thing in our own country. So I think we'll take questions in the end of the session. So let me introduce our next speaker, which is Cristiana Merendiero from Community Intervention Association Housing First Project. She's a project manager there, and she's a neuropsychologist working in harm reduction field since 2015. Currently the project manager of Community Intervention Association Housing First Project, which targets people who experience chronic homelessness and use drugs, and responsible for the implementation of a point of care HCV screening and treatment combined with outreach work. In the past has worked in a mobile low threshold methadone program. So over to you, Cristiana.
Hi everyone. I will share. Thank you. Hello everyone. Thank you so much for your interest in this presentation. My name is Cristiana Merendiero and I will present the REACH project, a point-of-care screening combined with nursing and peer-based outreach work to enhance testing and treatment for hepatitis C among vulnerable populations in Lisbon, Portugal. CIR is an NGO running since 2001, working with vulnerable groups in outreach settings, providing a set of harm reduction services for approximately 2,000 people per year including 500 with recent injecting drug use. CRCIR outreach teams operating in urban areas of Lisbon with high levels of drug consumption need to overcome barriers to care for marginalized populations of people who use drugs, people experience homelessness, and migrants that may not receive adequate support through the health system. These teams go by foot, with a backpack, and meet people in their environments. And I'm talking about drug trafficking neighborhoods, open drug use spaces, and abandoned buildings, just to name a few. This proximity approach is focused on reaching people who use drugs and who are in extremely vulnerable situations, being defined as hard-to-reach populations, promoting safer drug use and sexual behaviors through the exchange and distribution of sterile needles, syringes, and other injecting equipment, and also psychological and social support, medical and nursing care, and social and health referrals. Between October 2018 and March 2020, these teams performed on-site HCV antibody testing with referral to specialist assessment at the hospital. As you can see in the graphic, 133 participants were enrolled. Overall, 38% were HCV antibody positive, 76 among people with recent injecting drug use, and these 38 were referred for specialist assessment. Only 30% attend these appointments, and among the 10 people with detectable HCV RNA, 4 initiated treatment. So despite the high prevalence of HCV infection, there were considerable barriers to attending specialist-based appointments in hospitals for this population, which has led to suboptimal uptake of HCV therapy. So further work was needed to develop a novel model of care, a novel outreach model of HCV testing and linkage to treatment. And for this reason, in December 2020, CRCIR, supported by different partners, implemented an outreach intervention integrating nurse-led point-of-care HCV antibody and RNA testing, specialist appointments, telemedicine included, financial incentives, and peer navigation strategies. A specialized outreach team, a peer and a nurse, performed HCV antibody and RNA testing using the GenExpert HCV viral load fingerstick. For this project, CRCIR has created a specific partnership with a major hospital in Lisbon that is called Hospital de Santa Maria for referral people who are RNA positive to the centralized specialist assessment and treatment. So this partnership ensures that people attend their specialist appointments and get treatment at the CRCIR point of care. After the medication is available, CRCIR outreach team picks it up and provides it to the participants on site to maximize adherence. HCV clinical assessment is done at the end of the treatment, and the follow-up is run 12 weeks following treatment. In this case, 256 participants were enrolled, 31% were HCV antibody positive. Among the 31 people with detectable HCV RNA, 90% attended their initial appointment. These are the results that are very different from the other ones I presented to you before. And in February 2022, 14 initiated and completed treatment, and 14 were waiting for treatment. So these preliminary results point to an increase in HCV testing and treatment among these target groups, people who use drugs, people who experience homelessness, and migrants, when decentralized care and approaches are implemented. So in conclusion, the REACH project is an innovative approach that meets people in their environments and tries to answer their health needs to a decentralizing healthcare model and peer navigation strategies. Considering these preliminary results, we anticipate that prioritizing socially excluded populations and created people-centered interventions tailored to answer their needs will have a strong epidemiological impact on HCV eradication. Thank you so much for your attention.
Wonderful to hear about what's been happening in not only in the policy space with stakeholders in the first presentation, but then to see how programs can be refined to really move beyond just point of care testing to diagnostics and really improving linkage to care and treatment in the Portuguese setting. Now moving to further east across the globe and looking into the Indian context and seeing what can be happen within prison settings. We're going to invite Dr. Kanudeep Kaur, who is a pioneering public health professional, to give a presentation. With over 14 years of experience of working with people living in prisons, people who inject drugs and other populations, has identified a unique niche in that country to identify new innovations. So Dr. Kaur has a doctorate degree in forensic anthropology from Delhi University, and she currently works for FIND, which is the Global Alliance for Diagnostics.
Hi, a very good morning, afternoon, and evening, everyone. I'm Dr. Kanudeep Kaur, Project Lead Prisons HCV Project at FIND India. So at the outset, I would like to thank WHS for giving us this wonderful opportunity to present our work. Our work is on HCV microelimination efforts in the prisons of Punjab and Haryana, India. So to achieve the 2030 global targets for elimination of HCV, substantial scale-up of access to testing and treatment is needed, particularly among the prisons' high-risk groups such as prisoners. So it is estimated globally that 15.1% of the incarcerated individuals are living with HCV with very limited access to much-needed care. The state of Punjab has a population of 27.7 million with an estimated anti-HCV prevalence of greater than 20% in the high-risk groups of prisoners, while the state of Haryana has a population of 25.4 million estimated to have anti-HCV prevalence of greater than 10% among the prison inmates. However, very few prison inmates, they get a chance to have access to treatment while they're incarcerated. So the Health Department and Department of Prisons of Punjab and Haryana, in collaboration with FIND India, they embarked on a program to eliminate HCV among inmates in 18 prisons of Punjab and Haryana. The objective of the current intervention was to evaluate the efficacy of the decentralized HCV microelimination care model in 18 prisons across the states of Punjab and Haryana in India, and the 9 central prisons of Punjab and 3 central and 6 district prisons of Haryana, where the intervention was carried out, are shown here in the map. Let me take you through the prisons project HCV care pathway. All these prisons, they have a functional hospital and a battery of medical and paramedical staff. The medical team was trained for the management of hepatitis C. Rapid diagnostic tests were performed for all the prison inmates inside the prison, as well as for the new entrants. Inmates with positive HCV and positive HCV RDT result, they received the reflex blood draw for HCV RNA testing and baseline investigations. And the liver staging was determined by APRI and FIB-4 score. For non-cirrhotic is APRI less than 2 and FIB-4 greater than 3, less than 3.5. And for cirrhotic, all the cases with APRI greater than 2 and FIB-4 greater than 3.5 were termed as cirrhotic. So all the non-cirrhotic patients were initiated on treatment inside the prison by the prison medical officers, while the cirrhotic cases from Punjab, they were referred to the PGIMR Chandigarh for further management and specialized care, while for the Haryana, The cirrhotic cases, they were referred to the specialist at the Model Treatment Center at Postgraduate Institute of Medical Sciences, Rohtak. So both these MTC institutes, they have been conducting the OPD via teleconsultation to effectively manage the complicated cases remotely due to COVID-19. And also after 12 weeks of completion of the therapy, another HCV RNA test of cure is performed to evaluate for SVR12. Results, we have screened a total of 9,037 prison inmates in all the 18 prisons of Punjab and Haryana, starting from 20th November till 31st March 2022. Of those screened, 3,956 were HCV antibody positive, of which 90%, that is 3,596, received an RNA test, and 2,688 they were confirmed positive for the HCV RNA. Of the HCV RNA positive, 2,009 have been initiated on treatment till March, with 2% completing the SVR testing and 89.2% achieving the SVR. And during the peak COVID times, also the continuum of care was ensured, organized several expert consultation sessions using the ECHO platform to provide uninterrupted support. Approximately 30% of the total prison inmates, they were released to decongest the prisons amid COVID-19, following the decision by the high-powered committee constituted by the Indian judiciary. A lot of efforts have gone to re-engage the released inmates in the continuum of care. Out of 2,687 RNA positive detected, a total of 541 they got released, and of which 490 positive inmates got released from Punjab prisons, and the contact details could be managed for 277 of them, and of them 111 could be released successfully. Those contacted, they were categorized into 3 types basis their status, treatment, and were suggested the next steps accordingly. The first categories of those who have completed the treatment and were due for the SVR, they were referred to the civil hospital for getting the SVR sampling assisted by our project technician. And the second category of inmates who were due for their second and third treatment were directed to visit the civil hospital for collecting their next dose. Those with a treatment gap of more than 7 days, they were asked to get their SVR done again after 12 weeks before reinitiating them on the treatment. This is as per the national guidelines of Government of India. And the third category was of those who could not be initiated on treatment while in the prison. They were directed to reach out to the medical specialist for their treatment initiation. So of those contacted successfully, 47%, they were brought back to the care cascade. While in Haryana, only 51, they got released, and all the contact details were available for all these 51 cases, and out of which 30 have already been initiated on treatment, and they were thus handed over the remaining treatment refills at the time of release from the prison, and efforts are being made to link the remaining 14 to the care cascade. To summarize, under the project, we have screened a total of 29,937 prison inmates with 13.2% HCV antibody positivity, 2,688 they got confirmed with HCV RNA, and 2,009 have been initiated on treatment till March 2022 with 89.2% achieving the SVR. So this simplified, decentralized HCV testing and treatment model in prison setting is shown to be feasible and effective and acceptable in the Indian context. And lots of efforts have gone to re-engage the released inmates as this care model is fully transitioned to government partners. Additional efforts are being made to re-engage individuals released from the incarceration that had not completed all the steps in the HCV care cascade. So the experience gained by the prison system through this project builds capacity to expand HCV to district and sub-district correctional facilities in the future. At the end, I would like to express my sincere gratitude to all our partners for their involvement and unconditional support during the project times, and a special thanks to our project donor, the Gilead Sciences, and the WHS for this great opportunity. Thank you very much.
Thank you very much, Kanudeep Kaur. That was a great presentation. I think India is becoming a role model for hepatitis testing and management recently, and we can see why. So some wonderful work has been done. And also, I'm very glad to see that the released inmates were also re-engaged in the care. That was really a good move. I hope this is being scaled up to other parts of India as well. So I'm going to introduce our next speaker, Mr. Danny Morris, who is the regional manager of the Hepatitis C Trust. He's going to talk about hepatitis C test and treat roadshow, reaching homeless communities. So Mr. Danny Morris has extensive experience in the social care and health fields. Much of his work has been in substance use and development and delivery of detached community work with homeless drug users, outreach, HIV and HCV prevention to hard to reach groups, and management of comprehensive drug treatment services. Over to you, Danny.
Thank you. Yes. Welcome all. Thank you very much indeed for the host for giving me the opportunity to make this presentation. My name is Danny Morris. I'm a regional manager of the Hepatitis C Trust, and I'll talk very briefly about that in a moment. I'm presenting this on behalf of my colleague Philippe Bonnet, who's largely responsible for the delivery of the programme that I'm going to be describing. He's unable to be with us today. Sorry. A little bit about Hepatitis C Trust. Briefly, we're a national organisation in the UK operating since around 2001. It's a service user-led organisation providing advocacy, information support services to people at risk or with hepatitis C. We deliver this across community settings, prison settings, providing educational and testing treatment programmes across those systems. The core of our work is delivered by peers with lived experience of injecting drug use for hepatitis C to provide that education and training to both service users and staff in drug services, homeless services, indeed any environment now where people may be at risk of hepatitis C. And we combine with our partners within the NHS, the third sector, to deliver the UK strategy to eliminate hepatitis C by 2030. A brief summary of activities nationally in the Hepatitis C Trust. In the last financial year, our Follow Me, which is the name, the way that you describe our project, where our peers reach out into the communities, into prisons, find people and effectively get them, take their hand and take them into testing and treatment. And last year, nearly 25,000 people we delivered.
Sorry, Danny, sorry.
Sorry.
Are you presenting any presentation? Are you sharing a presentation?
Oh, is it not being shared? I'm sorry. I thought it was shared. Oh, my apologies. You should have stopped me earlier. I'm really sorry. That helps, doesn't it? Oh, that's really embarrassing. Let me start.
Please don't be.
I am, but I'll accept that. Sorry. That's I'll run through this. Sorry. My apologies. There it was. Happy looking at my presentation. There you go. I've covered this slide. My apologies to all for that technical hic. So I was just describing the work that we do kind of nationally across the UK. We provided nearly 25,000 people training awareness sessions delivered by members of our team, typically peers, people with lived experience. We tested 15,500 people, diagnosed 2,264 people. This is with peers, people with lived experience going out into the community, into prisons, actually doing the testing. We started 1,600 people on treatment and additionally trained 8,500 staff in allied services around hepatitis C, increased awareness. What led to our project development, to the kind of the rationale, is that we recognise significant numbers of people who use drugs, particularly those who inject drugs, poorly access drug and alcohol treatment. Now, historically, we've worked very effectively within drug and alcohol treatment services, where we reach large numbers of people who are currently or former injecting drug users. And we've been very, very effective, as our data shows, in reaching those people, supporting those services to get people tested and ultimately get people treated and cured. However, there's growing data that's showing that significant numbers of people who inject drugs are socially marginalised, socially isolated, have poor health outcomes, experience health inequalities, and are very poorly engaged in drug treatment services. And what we noticed, particularly during the pandemic, that many people that we were meeting through our outreach activities, even if they were on OST, opiate substitution therapy, for example, were poorly connected with drug treatment services during that period and getting very, very little support. And indeed, because we were recognising the very limited access to NSP, needle and syringe provision during that period, increased levels of sharing of injecting equipment. Okay, many were street homeless, residing in temporary accommodation, where often kind of injecting behaviours were compromised because of the environment they were actually in. Okay. So what we recognise that the traditional kind of hepatitis C treatment pathway, one that's described here, for example, works very, very well for people who are much more settled and established, more secure environments, are able to kind of follow that pathway. However, this pathway is increasingly breaking down for people who are less well engaged, less well served. So our projects are here. Our rationale was to kind of identify these significant numbers of people. The data across the UK was illustrating that this was very much the case, that there were people out there. For example, the opiate overdose rates amongst people in the UK has risen steeply over the last few years and massively overrepresented in people who are outside of drug treatment. And we know that drug treatment is a protective factor. Okay, so we're looking at people who are largely vulnerable and disengaged from services, often socially excluded and often unable to navigate complex, lengthy kind of pathways, the ones that we've just been looking at, the ones that typically we're kind of familiar with. And a very large number are unaware, as we discovered, of their hepatitis C status. And in fact, through our work, we became increasingly aware how many people are actually unaware of hepatitis C. They were vaguely aware, but they never kind of recognised the potential seriousness of being infected. What some of the studies did show is that many street homeless residing in temporary accommodation, as I mentioned, and we felt that what we needed to do was target an intervention. My colleague, Philippe Bonnet, who manages a small project in Birmingham, which is one of the largest cities in England, recognised that targeted interventions amongst homeless communities was a way of actually finding people through education, through contact and through testing and treatment. Okay, so our aim was to test people, and we utilised GeneXpert technology, point of care testing, to enable this to happen, because what we were recognising is that when we were testing people in other settings without this technology, it would typically take several weeks for an antibody, certainly for a PCR result to come through, by which time we couldn't find people, perhaps they moved on. And despite attempts to track people down, perhaps in areas they were begging or where they were homeless, it was often very, very challenging. We'd often lose people to the system. And using the GeneXpert offered us, trigger happy, obviously. Using GeneXpert was an immensely powerful thing to do. So Philippe, with peers, was going into hostel, providing very brief educational events, raising awareness around hepatitis C and inviting people to be tested. The majority of people that we asked to be tested agreed to be tested. And that was largely a feature and a recognition of the skills, of the competences and the engagement abilities of our peers to reassure people around testing and treatment opportunities. A large number of the people that we spoke to, once we developed support mechanisms for them, talked extensively about the stigma and isolation they felt around hepatitis C. And when we ran this program, this relates to activity over the last year, the last financial year. During that one project, and this was over 23 visits to services, homeless services, 660 people were antibody screened, and that was oral swabs. 285 of those came up as antibody positive. 50 self-reported as antibody positive and just went straight to Cepheid and felt, no, you don't need to antibody test me. I know I'm positive. Yeah, 335 of that group were tested, or the players were tested for RNA using a Cepheid machine that gives the result within an hour, and 149 of those were positive. And this was targeted testing, as I said. There was something there that we learned, the impact of the Cepheid machine, of the gene expert being able to give somebody a test result pretty much there and then, was quite profound. To actually watch it, it's quite hard to describe, but when you witness people experiencing the result, the peers were there to immediately support and to reassure, and that is important. I think we recognise we sometimes become complacent. So easy is DAA treatment now. We've sometimes become complacent about the impact of hepatitis C. And even those that we tested who were expecting to be positive or even knew were still often distressed around that. And we'd have to provide support. You know, people, for example, might be asking, can I cuddle my children? Their head was telling me it was okay to do, but emotionally they were often kind of challenged by that. So having peers on hand to reassure people was a really important part of this process. Once somebody was positive, there were two models here. One, we occasionally had nurses present who would then do the pre-treatment assessment. But in other areas in Birmingham, this large city, the peer support leads themselves were doing the pre-treatment assessment, would phone the nurse specialist while the client, the patient was there, offer the pre-treatment assessment. The nurse would then speak to the patient on the phone. Occasionally it was a video call, but typically it was just on a mobile call. Assessment was made. A decision was then made at the medical multidisciplinary treatment meeting at the hepatology department within days. A decision was made to then treat, and the peer lead was to go and pick up the medication from the pharmacy and then take it to the individual to start treatment. And that typically took anything around 2 weeks was on average, but sometimes it was as short as 2 days. It really depended on the sequencing of assessment through to kind of NDT through to pharmacy pickup, basically. But that's largely what happened. Okay. And at the time of the presentation, abstract presentation, 105 had been started treatment. That's now up to 136 of that cohort. Okay, so we found it to be an incredibly powerful, very simple way to engage people and get people into treatment. I think the Cepheid point of care testing was instrumental here. That combined with the ability of peers to engage the community that we're talking about, often very, very wary, quite resistant or reticent to access services. So the skills of our peers to engage people in the way to bring them into treatment was very, very evident. And it's a model now that's being rolled out in many, many other areas. It's incredibly kind of powerful. And it's something that we will certainly hope to continue in other areas. Thank you very much. My apologies for the kind of hiccups there. Particular thanks for the Hepatitis C Trust supporting this programme, NHSE, NHS England for funding the projects that we're delivering and having the opportunity to do so. And particularly our partners in the hepatology services in Birmingham with the ODN, the Operational Delivery Network in Birmingham, who provide the clinical support to all the people that we find and allowing us to find people and effectively bring them straight into treatment. Thank you.
Great, thank you very much, Danny. If we can ask you to, you've changed your screen, that's wonderful. Interesting to hear the use of, again, point of test diagnostics for PCR testing in other contexts and the use of peers, again, being able to identify people and really provide trust and support. Now we're going to move to Thailand, where Dr. Tanya Pornwansam will be presenting on community-based testing and treatment of hepatitis B and C and HIV in people who use drugs in that country. Dr. Wansam is the Director of Research at Dream Lockman Foundation in Bangkok and is the protocol chair of the C-Free study. She also volunteers as a study physician at the Thai Red Cross AIDS Research Center and is an investigator on the Hepatitis Transformation Science Committee of the AIDS Clinical Trial Group. So thank you very much, and over to you.
Thank you so much to the organizers for having us, and I really enjoyed hearing all the other presentations. And good evening from Bangkok. So today I'm talking about the C-FREE study. Sorry, it's not moving forward for some reason. Wait 1 second. Okay. So the primary objectives of our study were among people who use drugs and their sexual and life partners, where we were looking at HIV, hepatitis B, and hepatitis C prevalence. And then for those living with HIV, we wanted also to measure engagement in care and rates of viral suppression. And then finally, in those who are diagnosed with hepatitis C, we wanted to assess the effectiveness of community-based treatment using DAAs, or direct-acting antivirals. The really unique thing about our study is that we emphasize delivering one-stop shop diagnosis and treatment within community drop-in centers that offer harm reduction services. And these are community drop-in centers that were already established, and then we went and embedded clinical services within them. So our study design, we actually just came up on our 3-year anniversary, and we're the first study in Thailand to offer this community-based integrated Hep C treatment to active and former drug users and their partners. We currently are in operation at 7 clinical sites in 5 Thai cities, and I'll have a map later. And as I mentioned, we're embedded in these partner organizations that provide outreach and harm reduction services. Our inclusion criteria for our study, you just need to be at least 18 years of age and over, provide informed consent for testing and then treatment if you're eligible. And then you either need to have a past or current history of any kind of drug use. It does not have to be injecting, although we are targeting injecting drug users. You can also be a sexual or life partner of a former or current drug user. We have 2 parts of our study. So on the left, you can see the first part is a prospective cohort study. If you enter the cohort study, you receive HIV, hepatitis B, and hepatitis C testing every 6 months. And our testing is provided by nurses who are at the centers every day. They collect blood and conduct all rapid testing and then confirmatory gene expert testing. So many of the projects I've heard use gene expert, which I think is great for point of care testing. We offer HIV RNA, HBV DNA, and HCV RNA testing at our centers. If you're diagnosed with hepatitis C and are eligible, that is the next slide, is the eligibility criteria. We offer 12 weeks of sofosbuvir velpatasvir, which, as many of you know, is a direct-acting antiviral. It treats all genotypes of hepatitis C, so we don't do pre-treatment genotype testing. And these are our eligibility criteria. Our inclusion are any cohort participants who have detectable HCV RNA. We don't have a lower threshold, unlike the national program, which is 5,000 IUs and above. We assess cirrhosis by APRI-score, which I saw some other projects also use. If it's 2 or above, we refer for abdominal ultrasound to rule out hepatocellular carcinoma. And then we also draw and send specialty labs to assess for cirrhosis. So alpha-fetoprotein, and then the other labs, PTINR, albumin, and bilirubin. Our key exclusion criteria for getting treatment in our community centers are prior history of treatment failure, decompensated liver cirrhosis, hepatocellular carcinoma, pregnancy, and then end-stage renal failure, essentially. And then we do have some challenges with sofosbuvir velpatasvir. It can't be taken with ephedrins, which was still first-line treatment up until now in Thailand. And then if people have active TB and are receiving rifampin, they cannot take Hep C treatment. And these are our cohort results. And so this is our map of where we're located in Thailand. So you can see that we have centers throughout Thailand. In the Northwest, Chiang Mai Thai Drug Users Network, DAC, Give Hope. And then in Bangkok, we have 3 centers with 3 different partners, Rux Thai, Ozone, and APAS. And in the south, the border with Malaysia, we have 2 in Songkhla and Narathiwat. About a third come from the south. 51% are enrolled in the capital in Bangkok. And then about 16% are from the northwest. And then what I think is really great about the study is close to 80% of our cohort participants are referred by the community outreach workers that work for these or other actually community organizations in the area. These are cohort demographics. And so you can see that the median age, so we've screened over 2,000 participants and they're taking part in the cohort study. The median age is a little bit older, 40 years. The range is 18 to 77. Most of them are male. You can see a minority, 15% are either female or transgender. And then we actually have a lot of men who have sex with men, 14%. And there is a Hep C epidemic in Thailand among men who have sex with men currently around chemsex and group sex practices. Sorry, I don't know why it keeps going forward. You can also just see some other interesting demographics. So current injectors make up 40% of the cohort. And then if you're not a current injector, 45% report a previous history of injecting. There was also a high history of incarceration. 42% reported being incarcerated in the past. For HIV, hepatitis B, and hepatitis C, you can see that a third of our cohort is HIV infected, and 91% of those are on antiretroviral treatment. Of those, a little bit over 3/4 have an undetectable HIV RNA. So we have a little bit of ways to go on that. Close to 8% are hepatitis B positive. And you can see a third are immune. If they're not immune and are not infected, we also offer as part of the cohort free vaccination, the 3-dose primary series for hepatitis B, which is well received in Thailand. And then finally, our hepatitis C results, close to 60% are antibody positive. Of those, close to 80% were diagnosed with chronic hepatitis C, defined as above the lower limit of detection. And then 10% are actually cirrhotic by APRI criteria. Finally, you can see that there is a high rate of co-infection. So among those who have HIV, close to 70% were co-infected with hepatitis C, and this is not surprising among injecting drug users. Finally, we just want to present our excellent hepatitis C cure rate over the course of the study. And so this is a cascade similar to that seen, I think, in the prison talk that we heard earlier. Our per protocol SVR rate is close to 95%, which is awesome, I think, especially considering how many people are actively using during this time. And this, was previously actually exclusion criteria for treatment within the national program. Our intent to treat SVR rate, which would include anybody who was ever prescribed one pill of sofosbuvir or velpatasvir, regardless of whether or not they return, is still 93%. So that's all comers. But if you came to all your visits and then showed up for SVR, 95% of them were cured. We did an analysis of predictors of SVR, and interestingly, age, drug use status, co-infection status, APRI score, none of these were significantly associated with being cured. Although there is a trend, you can kind of see towards some differences, lower cure rates in younger age groups and higher APRI scores, which would not be surprising for cirrhosis. The only significant predictor in our analysis was being on ART and or having an undetectable HIV RNA. You can see the p-value here in those who are co-infected with HIV and hepatitis C. So some lessons learned from our study, which is ongoing and expanding. It's effective. So we have excellent cure rates among a traditionally difficult to reach population. We offer comprehensive care, and we actually have expanded to offer STI diagnosis as well as treatment, and then are looking to expand even further to TB and other diseases that are of interest to people in the community. We've also been able to re-engage those who were previously lost to follow-up or engage people in HIV and or hepatitis B care. So some people didn't know they were positive, some people did know, but they went to prison, they came out, they didn't have their health insurance scheme set up, so we can really help re-engage people in care. And we're really focused on using the information and data from our study to promote decentralization and access to care for drug users and their partners. Interestingly, right now, a lot of hospitals and other organizations actually refer to us for treatment because we do not have such strict criteria as the national program. And so many people are referring to CFRI, and we're actually included in many provincial programs now as a way to get hepatitis C treatment. And this is our study team. So we just want to say thank you and acknowledge our funders as well as all the participants who are entrusting us to take care of them and are coming to get tested and treated at our community centers, which are all listed here. And thank you for the opportunity.
Oh, that was a really great study, and you have done very extensively. We really commendable work. So I think we are done with all the presentations. Andrew, we should go to the question session, right? Okay. So, but we have seen some wonderful presentations on the topic, on the theme of this session. And I think we have some questions. I can see some questions in the chat box already. If you have any more questions, you can just write on the chat box or in the platform. There's a option for questions. I think I'll read out some of the questions and I hope speakers can address them. So just one second, I go to the platform. Okay, so my question to Ms. Kaur from India, like I think one of the question was about scaling up, and this is my question as well. So how do you plan to scale up this kind of microillumination project in other areas of India? And also one added question from me. So do you think this kind of microillumination projects is economically feasible for the government to fund from their own government fund in all throughout the country? Thanks.
Thank you for your questions, and I would like to answer the question number 2 first. So we are doing a cost-effective analysis of this entire study. But one thing I want to highlight here is that this is a very HR lean project that we have launched in India. And basically we have trained the existing prison medical and paramedical team. So it was more of like building capacities of the existing team. So I think this is a very much scalable and replicable and sustainable model. I mean, like if we are going to, I mean, like if governments, they are going to adopt it. And as far as the scalability is concerned, because this model has demonstrated a working model for microillumination among the incarcerated especially. So the efforts are now being to scale up. And the first thing is like the inclusion of the testing and the HCV screening for the inmates at the time of admission has been made part of the prison manual. So it will be like ongoing, even if like we have stopped the program or we have just transitioned the program. So government is taking up. Another is like replication of this model in district prisons. Like we have covered few of the prisons, and for the rest of the state, the government has taken up and they are replicating the model to the district prisons as well. So this is like totally government state-led initiative, which has already been like, they have started it up. And thirdly, I want to include like under the very recent Global Fund grant, which has been given to India under the NACO, National AIDS Control Organization. So through a partner organization, they are facilitating the intervention and they are trying to cover HIV, TB, because these departments have been merged in India. And alongside, they have also taken up hepatitis C also. So they are doing treatment, screening and treatment in prisons across several states of India. Yeah, thank you.
That's great to hear about the scalability of such an innovative approach. I think now we'd like to go to the first presenter, Dr. Hassan. Just, what work came out of some of the potential challenges for government and CSOs to, implement these strategies that came forward to find the not so low hanging fruit, and including what was the thinking around managing potential reinfection and enhancing adherence?
Thank you for the question. But we don't really look at the adherence controls. It's very much linked to the existing all those trials after will be linked to the adherence controls. It very much depends on that particular.
Could you adjust your earphones? We can't hear your volume very clearly.
Yes. Is that better now?
That's better. Thank you.
So it very much depend on the existing guidelines at the nearest healthcare clinic. All these clients they will be referred to the nearest healthcare clinic. So the adherence is very much similar to most of the healthcare clinics in the industry. So, but in this particular project, we don't look at the adherence per se. It very much depends on that. In terms of the whether reinfection, I don't think we look at that specifically for the reinfection. It's just a matter of if they don't respond to we probably going to retreat the patient. Probably the simpler approach rather than about people. I think if you are looking at this is beyond the radar of the patients. I mean, these are the patients who are particularly difficult to reach.
Could we ask you to put your comment in the chat? Just then we'll relay it because the sound was quite poor, and I'll hand back to Dr. Rahman to take the next question.
I think the same question is for Christiana as well, regarding the DAS adherence and reinfection. Maybe Christiana can answer first. And yeah, and also there's another question on Christiana regarding the how POC testing improved access to testing and access to care, and how are the learned lesson from POC HCP testing. So if you can answer the two questions.
So about DAA adherence, at the moment is 100% because as I show, we have around 28 people waiting for treatment, 14 and 14 treated. So everybody took the treatment and finished it. We support all of this on the field also in our daily activities. The other question was about reinfections, if I heard it correctly. Until now, we don't have any of our patients reinfected. However, we treated people reinfected in our project. So people that were reinfected in the past and right now are treated. We also do follow-ups every 3 months. As I explained, this is a very specific type of point of care. So we go to the neighborhoods, we took the tests to the neighborhoods and I'm talking about woods and abandoned buildings and this kind of places. So we meet people there and we do follow-ups. Normally we have a relationship with them and we do follow-ups every 3 months. I also read a question about the challenges we are facing right now. I would say that we faced in the past a problem with the RNA test. So we used the finger stick test, and we take the test to these settings in our backpacks. And sometimes when we return with the test and we put them in the machine that are in a fixed place, we find some errors in these readings. So right now we have the strategy to do it. We don't have this problem anymore. We also find another challenge that is related with the informal sources of income of our population. So people normally don't want to stop their activities, their daily activities, because they need them to earn some money that answer other necessities and very important necessities. So right now we overcome this barrier, finding partners to help us, providing financial incentives to this adherence. So, and the third and last challenge, I would say that is sometimes to manage these specialized appointments in our fixed point of care, especially during COVID times, because all the doctors were with a lot of challenges.
Thank you. We started a few minutes late, so I'm hoping we can go on a little bit to get Danny to have a question as well as Dr. Wansam. Danny, there was someone asking a great question about client satisfaction. Do you want to say a little bit around that, or or what others could be thinking to gather that information?
It's a fair question. I think it's something as a weakness, actually, because when we set this up, we didn't design this as it's an active project. We wanted to reach people and get them into treatment, and we didn't really consider that. Having said that, we had a lot of feedback, still get quite a lot of feedback from people. We have recorded that, not just from service users, from clients, from patients, but also from clinicians who are reporting engagement from a community of people they've never been able to engage before, and following them all the way through treatment. It's something we're going to do. One of the things I didn't mention, as well as doing the pre-treatment assessment and linking up with the nurse specialists to initiate treatment, if there are concerns around liver health, for example, then we will support that person to have them liver scanned, to have fibre scanned, or if need be, to ultrasound. But the thinking is to start treatment and then subsequently follow through with all the tests, and we found that's largely been successful. We will also do multiple BBB testing, not just Hep C testing. Okay, so we still have the opportunity. We are committed to maintaining support for all those people through to SVR 48 and beyond. So it'll be another year or so before we collect that data, but we now have the opportunity to kind of reveal some of the comments. What I would say is, anecdotally, we've had increased numbers of people being brought in by friends, basically, who had a very positive experience. And one of the things we hadn't counted on was people saying to us, for example, and this came up commonly, I've never been able to have an honest conversation with a nurse before. Yeah, and it's people that are starting to engage more effectively in other aspects of healthcare, and our peers will support them in that. So there's been some multiple benefits. We've not recorded them as well as we might have done, but we are doing that. We are looking at how we can do that retrospectively. It is an important thing. The quality of experience is key. It's something that you can see and observe. And I guess for us, it's a bit of a failing that we didn't consider recording that at the beginning. But the project, as I said, was led by peers, and their main interest is to find people and get them treated. And that was what drove the piece of work, and continues to drive the piece of work. But absolutely, we're going to explore that more. So thank you for the prompt.
Thank you. I think we can take one more question, right? Before we finish this. So question to Wansam, Dr. Wansam. I think there's a very technical question. I'll just read out. So how do you determine whether repeat positive viremia is reinfection versus non-adherence without a retrospective genotype? Or do you test for this but not wait for this prior starting treatment? I have another question from my side. I know your study was part of a larger cohort of drug abusers. I was wondering, if that cohort included all drug abusers of that area, or there were left outs, something like that. Yeah.
So I can answer your question first. It's open to any drug user or sexual life partner in that specific area. So we're open, and if people are interested, they can come to the community center. And like Danny said, actually, aside from the community outreach workers who go and pull people, and a lot of them are peer outreach workers. Once people started being cured, they were like, I'm going to bring all my friends here, because it's amazing that we can come here. We don't have to wait 6 months to get a HCV RNA, et cetera. So it's open to anyone in that community. And actually, after we were open, people didn't have so many options for treatment. There were people who drove, and people who still travel for an entire day to come to a center if they don't have one in their area. So we're open to anyone, regardless of nationality or geographical location, if they can make it to one of the centers currently. Regarding the technical question, that's an excellent question. And we actually do collect blood and store it for this exact purpose. When we do have a treatment failure, somebody doesn't clear, they have detectable HCV RNA. When we check their SVR, if they gave permission for us to store their samples at the beginning, we go first, we test their genotype at the time that they failed, and then we go back and pull the specimen that we stored and also compare the genotype at that time. And so we're pretty sure. And then we also have a little bit of money to do NS5A resistance testing and others. And so of all the people who consent to have their specimens stored, we are able to tell them, whether or not they were reinfected, and offer them Those who are reinfected actually in our study are offered retreatment, but those who feel need to, go to a specialist. So far in our study, we have collected information. The reinfection rate is 2.6%.
Okay, so I think we're at the end of our time, and we have to finish this session, but it was a really engaging session. I not only loved the presentations, but also loved the question. They were very pertinent. So bye from my side. I really enjoyed the session and learned a lot. Hand over to Andrew to give your concluding remark and close the session.
So I think what's particularly great to hear from different perspectives of the world is how important quality of care is. And really quality of care is relationships and taking services to people. And I think we know that, and just seeing when it gets done and we measure it, how much more effective it is. Just seeing the rates of retention and following along the cascade where the quality is good and you overcome people's realities and challenges, particularly if they're engaged currently in drug use, is really critical. And understanding that, people should have the ability to continue to use drugs. People should have the option to access healthcare, and it's our responsibility to do that in a safe and appropriate way. And innovation is great. I think coming from a middle-income country like South Africa, always the cost and the sustainability of the high-tech innovation of even the gene expert machines are questionable. And really the diagnostics are where we have to drive the price down and just get this to more people and scale up. And just thank you very much for these wonderful insights. I hope that you enjoy the rest of the conference, and it's been a pleasure for myself and Dr. Rahman to host this session, and we look forward to seeing you again soon. Thank you very much. Bye.
Thank you so much.
Bye, everyone.